Thanks, Elaine. Good morning, everyone, and thanks for the opportunity to be here to share some work from the Malawi National Program. I'm here on behalf of a large team of people to present emerging dolutegravir resistance among children and adolescents living with HIV in Malawi. I have the following disclosure. So in Malawi in 2019, in accordance with global guidance, the national program began the transition to dolutegravir-based antiretroviral therapy, initially for children and adolescents 20 kilograms and above, followed in 2021 with the arrival of Pediatric DTG, when we began the transition for the remainder of children to dolutegravir-based ART from both NNRTI and PI-based regimens. Many of these young people had prior zidovudine exposure, as the first-line therapy in Malawi for a long time was AZT3TC nevirapine. Everyone transitioned to either abacavir, lamivudine, dolutegravir for those under 30 kilos, or to TLD for those over 30 kilos and above. And these transitions often happened without available viral load results. Since that transition, we have seen an improvement in viral suppression rates among young people with HIV, but for children and adolescents, these rates remain below 85%, notably below suppression rates among adults, raising some concerns about potential emergence of dolutegravir resistance in this group. So in this presentation, I'll share a review of programmatic data looking at resistance patterns among children and adolescents with HIV from our national program who had accessed genotyping and had documented results. Malawi national guidelines now recommend HIV drug resistance testing for those who are on a PI or dolutegravir-based regimen for at least a year and have confirmed virological failure, defined as a viral load of greater than or equal to 1,000 copies per mil, confirmed after enhanced adherence counseling. To access genotyping, clinicians with eligible clients will submit applications to a national expert committee for approval of testing, following which the national lab will contact the clinician and organize for collection of a DBS sample, which is then sent centrally. Genotyping was performed on DBS samples at either the National Reference Lab in Lilongwe or in Johannesburg, South Africa. Drug resistance was defined as a resistance score of greater than or equal to 15 using the Stanford HIV database. So the results I'm going to share are a review of these testing applications and their available genotype results from the beginning of our genotyping program in December 2019 through November 2023 among children and adolescents 0 to 18 years of age, all of whom were on dolutegravir-based ART, failing dolutegravir-based ART in the national program. So first we'll look at the application cascade. And I should say this is among a population of almost 37,000 children. We had 302 applications for genotype that were submitted. 63% of them were approved by the committee for genotyping. 76% of those that were approved actually got a genotype to the lab. Of those that did arrive at a lab, nearly all of them, or a large proportion, amplified. So 91% of them amplified, and 73% of those had any resistance detected. We did find that 27% of those that amplified had DTG resistance detected. Now in this graph, this is a bit of a busy slide, but we'll look more closely at the resistance patterns among children that had an amplified resistance sample. Each bar represents a different ARV. The green represents susceptibility, and then the progressively darker levels of pink, orange, and red represent low-level resistance, and then intermediate, and then the red is high level. So overall, we had a large proportion of children and adolescents with resistance to NNRTIs. About 20% had resistance to tenofovir. About 40% had abacavir resistance, of whom about half had low-level resistance, and then about 30% with resistance to zidovudine. Overall, as I mentioned, 27% had dolutegravir resistance, and we had low levels of resistance to PIs, although most of the children were not on PIs at the time of the sample and had not been for several years. We had one child who had low-level darunavir resistance. So zooming in on the children with resistance to dolutegravir, among these 33, 61% of them were male. The mean age at the time of genotype was 10, with a range from 2 to 18 years. 80% of them were on abacavir 3TC with dolutegravir. 15% of them were on TLD, and 2 of them were taking zidovudine with their dolutegravir. The mean duration on treatment at the time of the genotype was about 7 years, with a range from just under 2 to 15 years on treatment, and the mean duration on dolutegravir at the time of genotype was just over 2 years. Looking at their resistance scores, one child had low-level resistance, just over half had intermediate, and 42% had high-level resistance to DTG. This pie chart is showing the most commonly detected resistance mutations and mutation patterns. Just over half had the R263K mutation only, and you can see on the other half of the pie the other resistance patterns. So in conclusion, we did confirm dolutegravir resistance among over 1/4 of the children and adolescents with confirmed virologic failure on DTG-based ART who had a genotype sample sent. I mentioned this is a very small number compared to the number of children in Malawi who are on ART. So it's important for us to look further into the outcomes of how these patients are doing. We're in the process of looking at that to see what regimens they were switched to. Some of them have not yet switched regimen, just related to the practicalities of receiving ART at over 800 sites across a very large country. So we're looking at how they're doing currently, and that information will be very important for us before we draw too many conclusions from this. But it is important to develop streamlined protocols to detect resistance early and define practical adherence support and ART switching strategies in this group of young people. I have an army of people to thank for the opportunity to present this on behalf of a very large number of people taking care of children and adolescents in Malawi. And thank you again for the opportunity.